Welcome everyone to this webinar. My name is Rodrigo Neiva. I am a diplomate of the American Board of Periodontology, as well as a diplomate of the International Congress of Oral Implantologists. I currently serve as a graduate program director and associate clinical professor in the Department of Periodontology, University of Florida College of Dentistry. Today's webinar will be on osseodensification, which is a new concept in implant dentistry, and it is considered to be a paradigm shift in this field of dentistry because it is really focusing on things that we haven't really necessarily paid much attention at the past, or maybe we have looked at solutions in the wrong place. So first of all, let's talk about bone. That's where all our implants are placed, or should be placed at least. And bone is a very unique tissue. It is composed of cells, collagen molecules, mineral crystals, as well as ground substance. Bone is extremely tough, yet is very lightweight, highly adaptive. It is also multifunctional, and it has a remarkable capacity of self-repair and healing. Bone is flexible, so that it can absorb energy, and bone can absorb high levels of energy. Bone is also capable of deformation without fracture. Of course, in extreme situations, fracture may occur, but bone is capable of withstanding a significant amount of deformation before a fracture takes place. Bone is also able to widen in compression as well as lengthen in tension. Bone is also very irregular as well as viscoelastic. It is irregular because it has different levels of density throughout its composition. As you all know, you have cortical bone, which is extremely dense, and trabecular bone, which is not as dense, but the level of density varies significantly based on function and different parts of the body. But what is important to remember is that bone is viscoelastic. In implant dentistry, we know that bone bulk is the code to success, which means the more bone available, the easier it is to place implants, and that's why we have developed our methods of bone augmentation over the years so that we could maximize the amount of available bone present for implants to be placed. Bone behavior in terms of strength is also directly related not only to its bulk of mineral density, but also its collagen integrity. So the way bone is managed during osteotomy preparation or implant placement is also important, so that the positive responses that bone should provide to the process of osseointegration can actually take place. Dental implants have significantly changed the way we practice dentistry. Implants are now considered to be a standard of care for replacement of missing teeth, either in full arch, partial arch, or single tooth replacement. We have evolved significantly in our techniques and materials used for the replacement of missing teeth, and we have not only achieved significant levels of success, but we had also been able to transform that into extremely aesthetic replacements that to the naked eye sometimes it's even hard to distinguish a tooth from an implant-supported restoration. Implants have come a long way to achieve this level of predictability. As you may or may not know, implants have had many forms and shapes over the years. The initial shape, one of the initial shapes that was suggested, was the use of blades. Implants had this shape in the past, which was actually a very clever shape, in my opinion, because when an implant has the shape of a blade, it doesn't need as much bone for its placement. So if a patient is edentulous, normally edentulism is associated with an absorbed or an atrophic ridge. That being said, a blade implant has it's simple to be placed, or it should be easy to place an implant that has this form in a resorbed bridge. The drawback of these implants is that they usually didn't have very good primary stability, so many of them would fail during the healing phase. Immediate implant loading, for example, or immediate provisionalization wasn't even considered an option back in the day. Other forms of implants that were used also include needles. Needles it was also easy to place this type of implants because it didn't depend on as much available bone for placement, but also its indications were limited. Especially a restorative aspect was a bit challenging. They were used for to support dentures or overdentures, as well as in combination with other types of implants, such as blade implants, or even to provide additional stability to subperiosteal type of implants. Other designs that have been used, have been suggested over the years as part of this whole evolution, also include the plateau type implants. These implants were designed so that you would have more surface area, which hopefully would make up for a lack of bone quality. This was one of the very early and clever designs that were looking at implant geometry in a way to make up for lack of tissue quality. These implants are still in use by few, but they also lacked in primary stability, and the challenge with these implants were also the use of early loading or immediate loading. Other types of implants that have been suggested or used over the years also include the cylindrical or press-fit type of implants. These implants were basically stabilized by friction. They would be tapped in place, most times with just as we would osteotome and osteotomy. These implants were inserted. They achieve higher levels of implant primary stability, but since sometimes the friction was too high, the body didn't seem to respond very well to them, and some of them would fail early on or develop a significant amount of crestal bone loss around them just based on too much compression of that cortical bone that surrounded the implant. That's why implants finally found the design that seems to be mostly accepted nowadays, or the design that has achieved the popularity that implant dentistry has these days, which is the screw type of design, which is widely used. So what's the rationale for this type of design? It really helps in different types of indications. It really has proved to have high long-term success rates, but it also has a versatility of use, which some of the previous designs did not have. So implants seem to work well for some situations, but not for all kinds of situations. And that's the beauty of screw-type implants, or root-form implants like we call them nowadays. There's very vast research to support them, and this has really coined the beginning of modern implant dentistry. So when we go through this whole evolution, we can look at it from this diagram, which basically kind of like outlines how implant dentistry has evolved since the introduction of modern implant dentistry. So back in '81, Dr. Albertson and Brandmark, they defined the key factors for reliable osseointegration, which were dependent on implant material, preferably titanium or titanium alloy, the design of the implant, which should be a screw type, surface conditions, that's how the surface of the implant was prepped and how sterile it would have to be. Also the status of the bone where these implants were being placed, the surgical technique associated with the placement of the implants, and more important than anything, implant loading conditions. Based on the designs that were present back in '81, the recommendation was for at least 6 months of healing in the mandible prior to use, or sometimes 8 or 9 months of healing in the maxilla when used in the maxilla. Most of these implants were contraindicated to be used in the posterior maxilla. And this is what has changed in the 90s. Most of the research that happened in the 90s happened as almost like a direct fight between machine versus rough surface implants. Machine implants were the original ones that had been introduced, and the rough kind was the one that was introduced later, with the claim that by having a rougher surface, you would have more bone-to-implant contact, and hopefully better, higher levels of osseointegration. This would also help make up for the poor quality of bone that was found in some areas of the mouth, for example, the posterior maxilla. So, based on the high success rates that this implant showed to have in areas of poor bone quality, this was the surface treatment that became a standard in the industry. So, all implants nowadays have some type of a rough surface that can either be like acid etch or sand blasted, or there are different kinds of methods that can achieve surface roughness. But so instead of changing the instrumentation of the implants, what happened in the 90s was they changed the implants to make up for the poor bone quality that was found in some areas. So this allowed implants to be placed in areas of poor bone quality, but still, like, loading protocols were very, very conservative. In the 2000s, that's when most of the research happened related to either the macro or the micro design of dental implants. This allowed for predictable, premature, and immediate loading of implants. And it also helped us understand the difference between primary and secondary stability. I'm going to go through that a little bit more in this presentation. After that, after we started to understand what kind of surfaces were more adequate for implant placement, finally we reached, in 2012, the introduction of a hybrid design, which is an implant that had different types of materials on it. Here we have trabecular metal, which is a composition of titanium and tantalum, two metals that are capable of achieving osseointegration. And with this hybrid design, you would have an implant that would maximize primary stability and be prepared to facilitate or maximize secondary stability. So in essence, this implant is designed for a very premature loading. Again, I'm going to cover primary and secondary stability, and maybe people will understand a little bit better what the rationale is behind this type of implant design. And finally, in 2014, this is where I think the industry will change for better, or has changed for better. This is when the osseodensification was introduced. This is a concept that has been studied extensively in the past. This is a result of many years of both preclinical and clinical studies that have led to a change in the instrumentation of dental implants. With this change in instrumentation, we should be able to maximize osseointegration in very challenging situations. and even like optimize our predictability in cases of immediate loading. So we keep talking about stability. What does it mean? What's the meaning of stability in implant dentistry? We know that there's only a certain level of micromotion that the body can tolerate before an implant fails. If there's too much micromotion, which means the implant is moving inside the socket, fibrous connective tissue encapsulation will take place and no osseointegration will happen. So the issue is always related with this micromotion. So how can it be minimized? We know that certain implant designs can maximize stability and hopefully minimize this micromotion, and that's why we have the capacity to load implants prematurely nowadays. So when we have this issue of micromotion, basically what happens is that micromotion may induce bone resorption, and once that happens, the osteoclast will enter the gap and start to widen it, creating something like a fragment mobility, which is similar to strain theory, and this will lead to fatal cell strain and no osseointegration. Also, initial implant stability is dependent on bone density. So the higher the bone density, the more predictable it is for implant primary stability to be achieved, and the less likely it is that micromotion will take place, and this will affect the integration of the implant. So it's important to remember that primary stability can be remarkably decreased in low quality bone. That being said, what's the difference between primary versus secondary stability? Primary stability is when an implant is placed and achieve a certain level of insertion torque. So this is directly related to bone quality. So imagine that primary stability is the pressure of the tips of the threads of an implant against the existing bone. The more bone that is present, the more bone density that is present, the more pressure you'll find of the tips of the threads against this bone. This is what creates primary stability. However, the pressure that the tips of the threads cause on this bone will decrease over time because this bone will start to resorb. So how can an implant integrate? It can integrate because while the bone starts to resorb at the tip of the thread, more bone starts to form between the threads. So in this area called the pitch of the implant, it's basically a chamber where new bone starts to be deposited. And this is when what we call secondary stability. So as the bone starts to resorb against the tip of the thread of the implant, more bone has already formed between the threads, and this is what will make up for the loss of primary stability. So primary stability, it's basically mainly dependent on two factors: implant macro and micro design, and the quality and the quantity of the implant surrounding bone. As you can see in this graph, basically by week number 4, we have this significant decrease in the level of primary stability. But if we have secondary stability that is already kicking in at a certain level, we can the body can make up for this this loss of primary stability, and the implant can still be successful. And that's basically why we can successfully load implants nowadays. Once again, looking at this graph here, imagine that the primary stability is coming from the tip of the threads of the implant, or the tip of the threads of this screw, and the secondary stability is coming from the newly formed bone that is growing between the threads of the implant. So that's the area of attention when you look at an implant that is healing. How much bone is actually forming inside that gap. Instrumentation. How do we instrument bone so that implants can be placed? The truth is that over the years, all the research was spent on how the implants had to be designed to maximize its success, to maximize its applications. But very little attention has been paid on the instrumentation aspect of implant dentistry. So the truth is that the medical profession has tended to adapt commercially available instruments that have been developed for drilling other materials other than bone. So these drills, they work. That's why we use them on a daily basis. But it's important to understand that they have significant limitations when drilling bone. So when you look at these drills, you can see the familiarity that they have with the regular implant drills that we use on a regular basis. The main reason why they are similar is because the design was copied from them. But these drills are designed to drill materials that have uniform density. So if you ever have time to spend on the weekends at your local hardware store, you're going to see that there are specific drills for wood and some specific drills for metal. They have specific differences in terms of design and material that they are made. And this is designed to overheat, to protect the bone from the materials or the drills from overheating, and especially for these drills to remove debris from the hole that they are creating. So the flutes on a drill, on a regular drill, are designed for that. The aim is simply to allow the debris to be pushed out of the osteotomy or out of the hole. If the debris cannot, it's trapped inside the hole, what happens is that the drill will burn and no drilling will take place. So that's the main reason why they have these flutes. Again, only the tip has cutting action. The sides of the drill have absolutely no cutting action. So this is very effective for materials that have uniform density. However, bone does not have uniform density. Bone, as we mentioned before, is structurally extremely irregular. This density can change every other millimeter. And when these drills are used in bone, they lead to lack of accuracy. So over the years or with experience, we managed to overcome that. And we are constantly controlling this shattering effect that these drills have when drilling bone. However, this lack of accuracy of these drills can sometimes lead to inaccurate implant placement or too much time spent inside bone with this drill. It may also affect the temperature inside bone, in other words, overheating bone or increasing the temperature too much. That may have detrimental effects on bone as well as the implant that is going to be placed, and this may affect osseointegration. So this lack of accuracy is something that is very significant with these conventional drills that are used for drilling of implant osteotomy. So as I mentioned before, a lot of research was done to maximize or to improve the way we drill implant osteotomies. And this is the first company that has focused only on that. Versa has introduced the term of osseodensification, which I'm going to be talking more and more about it now. But this is something that has been designed specifically for the drilling of implant osteotomies or drilling bone. So what's the difference between this Versa densifying drills or regular implant drills? The regular implant drills, as I said, they were basically designed for the drilling of materials that have uniform density. The design of these drills allows for much more accuracy because, first of all, they are taper in design, and the flutes that they have in these drills allows them to have cutting effect in both clockwise and counterclock motion, and that's what allows this burst to also work as a densification instrument. So based on its design, these drills, they will allow for real-time haptic feedback. That is just intuitive to inform the surgeon that either more or less force is needed at an instant. That's something that conventional drills do not provide to the surgeon. So the main advantage of this design is that it allows this osteotomy to be extremely precise, extremely controllable. This allows also for adjustments at every minute or every second when the implant is being drilled, which will allow for much more accurate implant. So, as you can see in this image here, you can imagine this drill working as a fan. What do I mean by that? A fan can either blow against you or towards you. When you have this drill being used in a clockwise motion, the fan is blowing towards you. When using counterclockwise motion, the fan is blowing away from you. And that's what allows this material to be used as a densification device. So this basically allows the surgeon to make these flat adjustments to the advancing force depending on any given situation of bone density. This is just an example of how accurate the implant osteotomies can be when using instruments that have been designed specifically for bone drilling. So another effect that you have with this type of drills is what we call a compression wave. This compression wave is basically a bone that is compressed laterally by continuously rotating and concurrently advancing the burr. So if you look at this design, you can see exactly what the tip is doing. The tip is creating cutting, but also the sides, the flutes are also helping that. This taper design, as I mentioned, you also allow the surgeon to lift away from contact so that you can provide more air and water irrigation while the osteotomy is being prepped. So as you can see here, this adjustment can be done very instantaneously and really helps with the accuracy of implant osteotomy preparation or bone drilling. Now, as you can see in a side-by-side comparison, traditional drill design compared to the Versa burrs that have this more specific design for implant osteotomy preparation. What is also important to understand is that these drills are universal. So the company has drill charts that will help you place any implant that is available on the market. So you can, whatever implant that you use or whatever implant company that you're used to use, and whatever sizes are available, they have drill charts that allow you to pick exactly what you need. So next, I'm going to show you two videos which will help you understand a little bit better what the difference is between a regular implant drill versus a Versa or a Densa drill, those densification drills. So now what's going to happen is this drill will be used in a regular 1200 RPM in gel. Gel has uniform density. So these drills, they will be very effective in any material that has uniform density, as I mentioned to you before. So what's happening here is this. When this implant is inserted in gel, or this drill is inserted in gel, what's happening is that the drill is extracting gel from the bottom. And that's why it's creating this tunnel that would basically represent an osteotomy. So again, very effective for this type of material because it does have uniform density. If you try to do exactly the same thing with a Versa drill, you would have a different effect. Here, because it has a uniform density, you're going to see that this drill will have a tendency to shatter quite a bit because it's not extracting anything from the osteotomy. There's no gaps inside the material for this material to be pushed. So what's happening here is you see this tornado effect, which is basically creating a significant amount of vibration inside the material, and that's why it's not being very effective. So in other words, if you try to use the same design that was developed for bone drilling on other materials, you wouldn't be able to cut anything, because this is specifically designed for bone that has marrow spaces. So the whole idea with densification is that the bone debris, instead of being pushed out of the osteotomy and wasted, it's actually inserted into the marrow spaces, into every trabecular space within the osteotomy, creating a very continuous wall of bone throughout the osteotomy, and with that maximizing bone-to-implant contact at the time of implant placement. And that's basically what has created osseodensification. So how was this concept developed? This concept was developed, originated by regular osteotomes that had been used for sinus elevation. So conventional osteotomes have the capacity to densify bone. The problem is that the forceful nature of this osteotomes allow for a very significant compression of bone, and sometimes based on its force, it can be detrimental to bone healing. It can even cause fractures. It's also very traumatic to the patient, because every time you use an osteotome and a mallet, a patient will remember that. So how could you have the same effect with a rotary instrument? It's basically with this design. So the conventional design of osteotomes, or the taper design of osteotomes, was adapted to drills. So the specific angle of these flutes, and again, hundreds and hundreds of prototypes were used until they finally found what was the ideal angle for these flutes to have this type of motion, created what we now understand as being osseodensification. So if you look at this fan that I mentioned to you before, if you're using this on a regular clockwise motion, it's doing what we call extraction. Extraction means extracting all the bone debris from the osteotomy. So here, if you're not trying to densify, you're just going to have a very accurate implant osteotomy preparation. On the other hand, if you use this in a counterclockwise motion, you're still going to be able to drill your implant osteotomy, but you will also be pressing a significant amount of bone into the marrow spaces, increasing the density of bone in that area, which will allow for higher insertion torque or more primary stability. So osseodensification is basically this plastic deformation of bone due to the rolling and sliding contact with the densifying burr. Densification occurs when the densified burrs have lens to densify the materials as it drills into it. So that's basically what happens. The cortical bone, imagine that the cortical bone is being shaved into the marrow space. That's basically what this is doing. So if you can look at this osteotomy that is being prepped in a porcine tibia, you're always going to identify this halo of cortical bone that is almost, there's this ring of cortical bone that is around the osteotomy as you're densifying it. This is basically all this bone debris that is being inserted into the spaces. You can see that next to the auto osteotomy, which was drilled with a conventional extraction mode. So the use of the bone that is normally discarded to graft the inside of the osteotomy, or the inner aspect of the osteotomy, can also be considered to be autografting, which is basically using the patient's own bone, just redistributing that throughout the osteotomy to increase this level of primary stability. Primary stability as well as bone-to-implant contact. Let's look at this micro-CT evaluations, where you can see number C here. You have A, B, and C. But the specimen C is the one that underwent osseodensification. as you can see how much more cortical the bone is all around the osteotomy. This is all within the same specimen. This will allow for higher implant insertion torque and more bone-to-implant contact at the time of implant placement. So, as you can see here, this is the effect of osseodensification. You can see all this debris that instead of being washed out is left surrounding the osteotomy. But pay attention at the inside of this osteotomy, as you cannot see any marrow spaces. They're completely obliterated by bone debris. And this seems to be even more significant at the apical level of the osteotomy. This is another example of it. As you can see, there's very little bleeding that you'll find here. As the implant is placed into this space, some of that will be moved, of course, because the threads will have contact with this bone and will create this compaction, optimizing the amount of bone-to-implant contact at the time of implant placement. And this is an effect that is particular to this densification burst. So once again, if you look at this diagram here, the main goal is to fill all of those marrow spaces with bone debris, and with that, primary stability will be significantly increased. So this is the concept. Where's the scientific evidence? Well, as I mentioned to you before, many studies have been done to allow for the development of this instrument, and this is one of them. This was an ex vivo study that was done in porcine tibia, where they use robots to drill the implant osteotomy, so they have all control forces, and of course, same type of bone that was used, only porcine bone that was used, porcine tibia, which is extremely soft. And here the comparison was conventional implant osteotomy preparation, so regular drills. Then you have the Versa drills in extraction mode or clockwise motion. And then you also have the Versa drills in densification motion or counterclockwise rotation. After that, the implants were placed, and the implants were tested for insertion torque, as well as RFA, which is Ostel values, as well as reverse torque analysis. So this is just an example of the osteotomy that was prepped with the densification system. So, another thing that was evaluated was bone mineral density throughout the osteotomy. And you can see here again on example number C, or letter number C, where the densification was used, how you can see a lot more bone density around that osteotomy. This allows for also significant changes when this specimen underwent mechanical testing. The mechanical testing, if you compare standard drilling versus extraction drilling and osseodensification, you can see significant higher insertion torque for this type of osseodensification drilling as compared to conventional drilling. As you can see in some of these osteotomies, with when the extraction mode was used, less insertion torque was achieved with the Versa drills as compared to standard drilling. That also has to do with the size of the osteotomy that is being prepped. Usually, when you use the conventional extraction drilling, or the standard drills that are used in the industry, we're always undersizing the size of the osteotomy, and that's where most of our primary stability comes from. So there's usually a 0.3 to 0.5 millimeter difference between the size of the osteotomy and the size of the implant that is being placed. That's what gives us primary stability. But that also maximizes the amount of bone compression that is taking place, especially the pressure that is being applied to that bone by the tips of the threads of the implant. So when these drills are used in the extraction drilling mode, what happens is that you're not undersizing it as much, and that's why sometimes you'll see lower insertion torque values. So that's something to keep in mind too. Sometimes when using the densification drills, you have to adjust what you're doing. So sometimes you have achieved already maximum densification of a site, but you still haven't finished your osteotomy preparation. So then what you have to do is you have to extract some of that bone and then reinsert it again with the next drill, so that you won't have too much bone being placed in the osteotomy, and then you won't be able to continue the osteotomy preparation. So there's only so much densification that can happen at once. So when you look at there's three different types of osteotomies, you can clearly see that halo of cortical bone that is present when osseodensification is applied. Let's look at this at a micro CT level, and you can also see like the very significant radial density present when osseodensification was used. The same applies when this is looked at a buccal view, as I showed you before, how you find this higher cortical bone-like structure surrounding the whole osteotomy, almost looking like an artificial lamina dura that was created with the osseodensification concept. When these implants were placed and then histology was done, you can also identify how much higher the osseodensification bone-to-implant contact was as compared to the other types of implant osteotomy preparation. You can see that every space between the thread, or the pitch between the threads, have been occupied by this osseous debris, which basically act as a glue, acting as a filler and maximizing this bone-to-implant contact and implant insertion torque. So, in conclusion, bone-to-implant contact was 3 times higher for osseodensification versus standard drill preparation or drilling of the osteotomies in this model. Osseodensification has also shown to increase the bone mineral density around the periphery of the osteotome hole. It also showed have significant higher insertion and removal torques, because the torque was checked both at the time of insertion and at the time of removal. Osseodensification also has shown to have similar clinical safety to standard drilling, which means you're still using the same rotary speed and the same type of penetration speed and irrigation used with conventional osteotomy preparation. Osseodensification also creates a smaller hole than drilling due to recovery of elastic strain when the osteotome is removed from the hole. So basically, because you're creating the osteotomy and you reinsert bone inside that osteotomy, the size of that hole seems to be diminished. And that's why with this densifying drills, you do not under-prep the implant osteotomy. In essence, when you use a 3.8 millimeter drill, for example, a 3.8 millimeter drill with the Versa system, you're using that to place a 3.8 millimeter implant. Why? Because the size of the osteotome is 3.8, but since so much bone is being reinserted there, and there's just going to be so much bone-to-implant contact at the time of implant placement, you have optimal placement with this type of osteotomy. You try to do that with a conventional implant drill, you're always going to have an implant that will be spinning inside the osteotomy. So this bone densification techniques, it basically autografts bone by reapplying ground particles in a compacted manner along the entire depth of the osseodensification hole. So this seems to be very uniform throughout the whole osteotomy. So like I said to you before, the irrigation is also helping with removal or compaction of this debris. So there's some hydraulic motion that is also taking place. One thing that is important to remember is that when we're using any conventional implant osteotomy preparation systems, or even the Versa drills in extraction mode, here the fan is blowing towards you, which means every drop of irrigation that you apply to the tip of that drill is coming back at you. So there's very little cooling effect that is taking place unless you use drills that have internal irrigation. So when you use a drill that has internal irrigation, then the irrigation is going to the tip of the drill and just being pushed back all through the whole osteotomy through the flutes of the drill. when you use the densification drills, because the fan is blowing, away from you, what happens is that all the water that or all the saline solution or all the irrigation solution that is hitting the neck of that drill is being pushed very forcefully into the bottom of that osteotomy, creating some hydraulic motion as well. This is especially important when this is being used in the posterior maxilla, because this hydraulic motion can also help with like crestal sinus elevation, and we're going to show a little bit more of that in a little bit. So let's go through more histologic evidence. This is a part of like a series of studies that we have been doing, evaluating this Versa system, and this is in a different model. This is an in vivo model. These osteotomies are being drilled in the hip of sheep, which is an extremely soft bone, and excellent model for testing of insertion torque and methods to optimize insertion torque. So here we have the same comparison. We have standard implant osteotomy preparation, clockwise or extraction mode we're using Versa, and counterclockwise or densification mode using Versa. So just by looking at insertion torque, what we managed to do in this very soft bone in the control specimens was to have an average of 5 to 10 Newton centimeters of insertion torque. So when more torque was applied to these implants would start to spin. When this same implants were placed in the same hip using the Versa extraction system, we had a significantly higher insertion torque, which gave us 50 to 60 Newton centimeters of insertion torque in an extremely soft bone. But when the densification system was used, this insertion torque reached all the way up to 100 Newton centimeters of insertion torque. So this is very interesting, great. But we know that this may be a little bit too much, and we were afraid of what we were getting when we were seeing these numbers, because we didn't know if this would be helpful for bone healing or if this was going to be detrimental to bone healing, because are we creating too much osteocompression? Are we killing the bone by maximizing insertion torque? That's what we were afraid of. The truth is that since we are not maximizing the pressure of the tip of the threads against living bone, but we're simply like filling the whole space with bone debris, the truth is that we did not see that. We saw exactly the opposite of it. So if you look at the control specimens versus the Versa extraction and the Versa densification, you can see, and this is only at 3 weeks. 3 weeks later, these animals were sacrificed and the hips were removed for histologic analysis, and you can see like how densely compact bone is surrounding this implant that was placed only 3 weeks prior to. And these were exactly the same implants, exactly the same animals, and you can just see how much more bone compaction and how lamellar in aspect this bone is as early as 3 weeks after placement. So this did not have any negative effect in bone healing. It only maximized the amount of osseointegration that was achieved here. And you can see this in a little bit higher power, comparing control versus extraction mode, and also the densification mode. And now with even more power, you can understand the difference between primary and secondary stability. So the control specimen did have some good bone formation in between, but nothing compared to the extraction and densification mode that was achieved with this system in these specimens. As you can see here, this is all vital bone with osteocytes in the lacunae. So there's also some clinical evidence of this system. And this is a part of an ongoing clinical trial that has placed 120 implants in 77 patients. So with these implants, when these implants were placed, all types of measurements were taken at the time of implant placement: 1, 2, 3, 4, 5, and 6 weeks. And the Osseodensification implants were subject to at least 30 Newton centimeters of reverse torque test at 4 weeks and at 6 weeks in the maxilla, just to assure that significant primary stability was still seen after implant insertion. So as I mentioned before, this is how the study was designed, with a very constant analysis of this implant stability, both by RFA and reverse torque analysis at both 4 and 6 weeks. So this is just an example of reverse torque analysis, both in the maxilla and in the mandible. So here you can see another clinical case of this implant at the time of implant placement after densification had been applied, and 60 Newton centimeters of insertion torque. Primarily, stability of the implant, of course, achieved at 60, and then RFA analysis of the same implant, and later on this implant was restored and has remaining function since then. So with this study, what we are seeing is that we are seeing a very significant level of insertion torque without affecting implant survival or implant success. And most of these implants, based on this high insertion torque, have been loaded or permanently restored very, very prematurely. So in this off of this 112 studies, 12 implants that were placed, in two cases, we seems to have some bridge augmentation was used at the same time. 8 cases had some type of sinus grafting associated, and 2 different types of implants were used. So in conclusions here, only 2 implants did not osseointegrate, and they seemed to have some association with previously grafted sites and the graft that had not turned over properly. It's shown that osseodensification seems to be a safe surgical protocol, and also has promoted some enhanced implant healing over the 4 to 6 weeks healing period. There's another study that is going on here. This is also a study with 28 implants placed in 12 patients. And this 28 implants, 14 of them were placed with standard extraction drilling, while the other 14 were placed with osseodensification system. And these implants were placed in the same patient, so this is a split mouth type of design. And the patients were also subjected to a reverse torque test at 4 weeks in the mandible and at 6 weeks in the maxilla. If you look at the graphs, you can clearly see the insertion torque value being significantly higher when osseodensification was used, and this seems to have remained constant throughout the evaluation period by measuring ISQ or osteo values. So this has also shown to be highly significant in terms of the ISQ compared to 0 to 6 weeks. As you can see here, a very constant number has remained throughout the osseodensification, throughout the period in the osseodensification group, while a drop was seen in the conventional standard drilling, which in some critical situations like immediate loading could have been the difference between a failed implant versus a successful implant. What this next slide also shows you is that this seems to have been constant not only in the mandible but also in the maxilla, while the difference was significant both in the mandible and in the maxilla throughout the evaluation period. And the same thing can be seen in these graphs here. So what are some other applications of osseodensification other than just densifying bone to promote more primary stability and hopefully premature loading of the implants? We have looked at this in different types of clinical situations, and a very interesting indication or very interesting application of this system seems to be in crestal sinus elevation. As I mentioned to you before, when this bone debris is being pushed into the osteotomy, it will densify bone. but it can only densify for so long because it will fill the bottom of the osteotomy with too much bone debris, and then you may have to extract some of it so that you can place the implant. But what happens if you don't have a bottom to your osteotomy? Basically, what would happen is that all that bone debris is going to be pushed into the sinus cavity, and that's basically what we can consider this to be sinus autografting, which is basically just removing bone from the osteotomy, and this debris is being constantly inserted into the sinus cavity. Together with the water that is being pushed into the sinus, this can create a hydraulic lift and can help increase or elevate the level of the floor of the sinus. As you can see here, this is a very challenging situation for a crestal sinus lift, where the same densification drills was starting to be used, and you can start to see the radiopacity at the bottom of the drill, and finally the implant was placed into that space without the addition of any other grafting materials. As you can see here, now with 8 weeks restoration, you see a good densification of the bone inside that sinus, and now in 1 year follow-up, it seems to have remained constant without the addition of any type of bone grafting. So this can be used by itself, or it can be used in combination with graft materials. I tend to prefer this. So let me show you this example. This is a patient that has 7 millimeters of residual ridge height, which normally this would have been a good indication for a Summers osteotome technique or any type of crestal lift approach. What I did in this case is just decided to use the densification system. So I started to use my densa burrs. To my working length here was the distance from the crestal bone to the floor of the sinus, so my 7 millimeters. When I approached 7 millimeters, I felt the lack of resistance. So my drills, they don't penetrate inside the sinus, they stop just flush with the floor of the sinus. I let the water and the bone debris that is being pushed into the sinus to continue to elevate the membrane for me, not the drills. If you continue to push the drill into the sinus, against the sinus membrane, of course you're going to tear the sinus membrane. And that's not your goal here. Your goal is to simply detach the sinus membrane with the hydraulic motion so that it can be elevated and a bone graft can be inserted. What's interesting about these drills is that I mentioned to you, here the fan is blowing away from you. If the fan is blowing away from you, what you can basically use these drills as a Lentulu drill, for example. What is a Lentulu drill? Lentulu drill is designed to apply cement inside the canal of a tooth before you insert a post, or has some other indications in endodontics. So this drill can be used for bone compaction inside the sinus. So this is just a control radiograph that shows the radiolucency that is formed inside the sinus now by pressing or just by this hydraulic lift that took place with the osseodensification of the osteotomy. But then what I did was I basically filled the osteotomy with putty-form bone graft material. And now at 50 RPM, very slow RPM, I used the same Lentulu drill or the same densification drill as a Lentulu drill to push the graft material more apically. And this made it very easy for this type of sinus elevation to take place. So now the sinus was 7 and now it's 15. Again, we could very easily do this with a normal osteotome. Those of you who have done this in your careers before, you know that this is something that can be done with a regular osteotome, but not as gentle as you would be doing with this type of system here. So you can be very, very gentle and still be very predictable with this type of crestal sinus elevation by using this densification system. This is another example of the sinus autografting. And as you can see here, these two osteotomies that have been drilled, one of them, the one on the left, is the one that has already seen a good amount of densification or bone debris being pushed apically. The second one on the right is the one that's still going to have to be a little bit more expansion before you see this new floor of the sinus created with the bone debris that is being pressed into the floor of the sinus. And as you can see here, this is just like an immediate post-op, and you can see the halo of bone that has been created or has been pressed into the floor of the sinus. And this is just allowed to heal, and now the patient returns, and you can see that the level of densification is a 10-week restorations. 10-week, the final restorations were delivered, and this is just a 1-year control, just showing how stable that can be also over time. Since these drills can in many ways be looked or considered to be a rotary osteotome, we know what osteotomes can do. They can also expand ridges. These drills can also have the capacity to do that. So when used in the densification mode, they have the capacity to expand bone. Of course, the narrower the bone, the more you can expand. And this is something that we understand very well from the use of conventional osteotomes for ridge expansion. So this is a protocol that has been developed. It's considered to be like a +1 protocol, which is basically this. If you have a minimum of 3 millimeters of alveolar ridge width, you can place a 3.7 or a 4 millimeter wide fixture, which is basically whatever residual ridge you have, you're capable of placing an implant that is 1 millimeter larger than the ridge that is present. Of course, this seems to be, it's always a lot easier to expand the narrow ridges than the wide ridges, and this is what this study has shown. Well, basically, when the ridges were in the 3 to 4 millimeter range, about 3 to 4 millimeters of expansion seems to have been like predictably achieved. When the ridges were only about 4 to 5, about 2 millimeters seems to be the average, while the ridges were about 7 to 8 millimeter wide. Only about 1.5 millimeter of ridge expansion seems to have been achieved. But this is a clinical tool that can help the placement of implants in narrow ridges. So as you can see here, you have a pre-op ridge of only 4 millimeters, and with this type of system, now you have a 7 millimeter wide ridge, which will facilitate the placement of a 4 millimeter wide implant, and still would have about 1.5 millimeters of buccal plate and 1.5 millimeters of lingual plate left. What's interesting about this system in this ridge expansions is that if you have a very narrow ridge, what you're going to be left with would be like a really thin layer of bone still covering the facial aspect of that implant. Of course, you would still have to graft over that, but some bone covering an implant surface is better than no bone. So that's where the advantage of this system would be. You would still be able to place the implant in a very accurate and controlled position. And if not enough bone was left on the face of that implant, you could still augment it buccally. So this is just an example of this technique. Here's another example. We have a ridge that is only about 4 millimeters wide at the crest. And now, after expansion, a 6 millimeter wide implant was placed, and this implant was had an 80 newton centimeters of insertion torque. 5 weeks later, five weeks later, the final restoration was delivered to the patient, and that area remains in function since then. This is another example of the potential for ridge expansion with this type of drills. This is in association with a ridge split, which was used to facilitate the expansion. And as you can see, that the osteotomies here were very, very controlled. That's why the surgeon managed to place the implants in these areas. But as you can see here, although you still have a thin layer of bone on the facial aspect of that implant, that will have to be grafted, of course. But instead of having like a complete dehiscence, there's still some bone present on the facial aspect of that implant. And here the case is grafted, and later on it was restored and has remained in function since then. Another example of the +1 protocol, you have a ridge that is only about 5 millimeters wide. Now the ridge has been expanded for placement of a 6 millimeter wide implant, and the implant is placed and also achieve a significant level of primary stability. Well, this is what I had to share with all of you today. I would like to thank you all for your attention, and I truly believe that this Osseodensification system has really added something very new to our profession, or to this to our specialty. This Osseodensification system, I think we have only seen the tip of the iceberg so far. Not until more clinicians start to use it that we will be able to understand more and more what it can do. But based on my experience, I think it has really changed the way I drill my implant osteotomies, and I hope that you'll have a chance to try that in the future. Once again, thank you for your attention. I wish you all well, and thank you again.